Association of India for having given me an opportunity to come and discuss this particular topic. The topic is MRI imaging in heart failure. I think one of the most important aspects of heart failure diagnostic assessment has been MRI ever since it actually began. Probably we joined the bandwagon quite early, and we have a very dedicated team of cardiac MRI imaging group, which so we have a combined discussions almost every week, and it is routine for us to do MRI imaging in all patients with cardiomyopathy. So what is the scope of my discussion? I'm going to talk to you on what is heart failure, why do we need imaging and MRI in heart failure, some of the basic techniques, LGE, T1, T2 mapping, specific disease entities, hypertrophic cardiomyopathy, NICM, ICM, etc. So what is heart failure? It is a pathophysiologic state in which the cardiac output is inadequate to meet the metabolic demands of the body. It is a complex clinical syndrome. I would repeat that. It is a complex clinical syndrome that can result from any cardiac disorder that impairs the ability of the ventricle to eject blood. When you ask residents what is the definition of heart failure, most of them get stumped actually. And most of them have difficulty in conceptually saying what is heart failure, and also difficulty in communicating. So I think this definition from ESC guidelines is probably the best. So heart failure is a clinical syndrome in which patients have the following features. Symptoms typical of heart failure: dyspnea, fatigue, tiredness, ankle swelling. Signs typical of heart failure: tachycardia, tachypnea, hepatomegaly, edema, and objective evidence of a structural or functional abnormality of the heart at rest, such as cardiomegaly, S3, cardiac monosis, abnormal echocardiogram, reduced LV function, ejection fraction, and raised BNP. So remember that it is a clinical syndrome comprising of the symptoms and signs of heart failure and the objective evidence of LV dysfunction. What is a prognosis? The average 5-year survival rate is about 50%. And one should understand that the risk of death is, with mild symptoms, is 5 to 10% annually, while it is 30 to 40% in severe symptoms. All indicating that we need to know what the problem is so that we can take care of what the disease is. So why MRI in heart failure? MRI in heart failure is so for the precise definition of ventricular size and ventricular function. It is important primarily because it allows tissue characterization. Today, it is the non-invasive biopsy that is possible to identify the cause of heart failure and to find an etiological assessment, to assess the prognosis and risk assessment, to assess arrhythmia in heart failure evaluation, to assess myocardial viability and perfusion, and of recently to do a QPQS in congenital heart disease, both in left to right shunts as well as in complex congenital heart disease with, for example, in bidirectional Glenn shunts. So that is the new kid on block. Now, what is the physiological basis of the late gadolinium enhancement, which is probably one of the bases of this MRI assessment in heart failure? The physiological basis of scar imaging is based on the tissue persistence of the contrast agent gadolinium. What does the gadolinium do? It shortens the T1 and increases signal intensity with consequent hyperenhancement, a difference of longitudinal recovery times as compared to the normal myocardium. The gadolinium diffuses from the vascular to the interstitial space and remains there. In the chronic scarred phase, the myocardial scar is characterized by increased collagen content and interstitial space, and gadolinium accumulates there here with delayed enhancement. As you can see here, in the normal myocardium, you find that the gadolinium occupies the extracellular space, which is much less, while when there is acute infarction, you find that cell is disrupted and the gadolinium enters intracellularly. And while in a scar, you find there is increased extracellular space, and the scar makes it persistent for a much longer time. So in fact, what happens is that following a contrast injection of the gadolinium, the contrast diffuses much slowly from the scar as compared to that of a normal washout, which happens much early. So when you image the myocardium at 10 to 20 minutes, you find that the scar is persistent and continues to be persistent with hyper-enhancement. So this LGE pattern that persists has an etiological pattern as well, and we will look at that, even though we will go into details a little later. So in the ischemic cardiomyopathies, you find that there is a subendocardial LGE persistence, and when there is transmural infarct, this persistence of LGE becomes transmural or more than 50% or more than 75%. While when you look at non-ischemic cardiomyopathies or conditions with heart failure with non-ischemic LV dysfunctions, when you look at the mid-wall hyperenhancement, it is characteristically seen in the mid-wall LGE, seen in dilated cardiomyopathy, myocarditis, hypertrophic cardiomyopathy. When you find epicardial, subepicardial enhancement, it is seen in sarcoidosis, myocarditis, and subendocardial concentric enhancement is typically seen with amyloid systemic sclerosis. We will come out to all these in detail, but this is an idea that the pattern of LGE conforms to the etiology. So one of the important function of MRI is in ventricular function assessment, especially ejection fraction. The LV and the RV ejection fraction and the dimensions are obtained with cine imaging. The ability to obtain images in all planes with good temporal and spatial resolution and reliable endocardial border detection. And perhaps what is most important is the independency of geometrical assumptions for volume estimations, which results in very accurate ejection fraction evaluations as compared to echo or any other, or even for that matter, based on angiograms, where you need geometrical assumptions. And this is particularly true in difficult anatomies such as RV ejection fraction. Now, what is T1, T2 mapping? Just a minute. Sorry, there is some problem with it. Sorry, there is some. Yeah, T1 mapping. Tissue characterization can be based on quantifiable differences in T1 values. The T1 value is the recovery rate of the longitudinal magnetization. LGE sometimes is not useful when there is diffuse disease or when there is diffuse fibrosis, as there is no zone to compare. So you need to have the actual native T1 and post-contrast T1 absolute values are measured so that it gives an idea. So T1 mapping thus refers to a pixel-wise evaluation of the absolute relaxation times, which can be put on a map and which is color-coded. The normal value is about 950 milliseconds for the T1. And high T1 values are seen with fibrosis edema, and low T1 values are typically seen with iron overload and lipid. Feasible in renal failure, especially when LGE is contraindicated. So if you look at this, you can see that in a color-coded T1 map, you can see the green is normal, and any value above that is as an increased T1 value seen in hypertrophic cardiomyopathy, DCM, acute myocarditis, systemic sclerosis, amyloid, MI, and the scar phase of ischemic heart disease. While a reduced T1 values is seen with iron overload and Anderson-Fabry disease and in lipomatous metaplasia. So typically, if you have a native T1 value, irrespective of the fact whether it is color-coded or not, these values can tell you what the likely problem is going to be. So let us have a look at the T1 map. Now, this is a patient with hypertrophic cardiomyopathy, as you can see here, and typically LGE, because most of you are familiar with the LGE, you find there is some amount of mid-myocardial septal LGE. And when you look at the T1 map, you can see there is a golden brown color indicating that the T1 values are increased, indicating fibrosis. That is quite clear and it's not very difficult. But when you look at patients, when you look at a dilated cardiomyopathy, you find here there is no evidence of LGE, while when you look at the T1 map, you can see the color is graded almost greenish to yellow. So yellow is, that tendency shows some amount of diffuse fibrosis. So this diffuse fibrosis would not have been picked up if you had looked only at the LGE. Now let us look at heart failure with preserved ejection fraction. You can see that there is no LGE at all. The LGE is normal, and you would assume that there is no fibrosis. However, when you look at the T1 map, you can see there is a yellowish color, which indicates a higher T1 value, indicating a diffuse fibrosis over the entire LV. So T1 map helps you when there is diffuse fibrosis. Coming to T2 map, it is a transverse relaxation time T2 of the myocardial tissue that is altered by disease. Edematous tissue with increased water content has elevated T2 values, such as typically seen in myocarditis. And an increased iron content, it reduces both the T2 value and the T2 star value. So let us again have a look. Now, this is a picture of a myocarditis, and this is the cine run, which of course it is not running, but it shows it has hyperkinesia of the lateral wall. And here you can see the LGE. The LGE shows typical mid-myocardial enhancement, which is not very difficult to make out. Now, let us compare it with the T1 map. You can see a golden brown color indicating increased T1 values, as well as an increased signal intensity on T2 weighted imaging indicating edema. So even if you did not have this LGE mapping, you will be able to pick it up with both T2 weighted imaging as well as with a T1 map. Now, coming to specific entities, now let us look at MRI in hypertrophic cardiomyopathy. Why MRI in hypertrophic cardiomyopathy? One, to assess the ventricular function, to assess the ventricular hypertrophy, typically asymmetric septal hypertrophy, to measure and have a look at the SAM, the mitral valve abnormality as typified by a lengthened anterior mitral leaflet, papillary muscle abnormalities, which we have seen having multiple heads and more than 2 papillary muscles, arrhythmic risk assessment using LGE. So when we looked at our data, we found that 56% of patients with hypertrophic cardiomyopathy do not have LGE, while 33% have a mid-myocardial and 7% have a subendocardial LGE. So this is a typical pattern of, you can see the concentric, the asymmetric septal hypertrophy, and you find the LGE on the septum. So what are the factors for risk assessment hypertrophic cardiomyopathy, and where does LGE stand? The typical risk stratification in hypertrophic cardiomyopathy is based on unexplained syncope, NSVT, family history of sudden cardiac death, severe LVH more than 30 millimeter wall thickness, and abnormal BP response to exercise. Now, to these, you need to add LGE. So we looked at the fact whether can LGE predict ventricular arrhythmias. So what we saw was that in hypertrophic cardiomyopathy, when you do not have LGE, only 10% of them had arrhythmias. Whenever LGE was present, there was an equal distribution of arrhythmias. Almost 50% of the arrhythmia was present and arrhythmia was absent in 50%. This is an interesting T1 map in hypertrophic cardiomyopathy, and what is the pattern? I think Professor Tarakan would be interested in this. Now, in people with LG positive and LG negative patients, the T1 values are increased, indicating that thereby a diffuse fibrosis within hypertrophic cardiomyopathy with or without LG enhancement, indicating that thereby these arrhythmic risk can be irrespective of the LG. So what did we learn? We learned that in patients with hypertrophic cardiomyopathy, ventricular arrhythmias in LG in MRI tends to correlate. The absence of late gadolinium enhancement on MRI carries a high negative predictive value for ventricular arrhythmias. Presence of LG was seen equally with and without ventricular arrhythmias, and by itself cannot be recommended for ICD prophylaxis. It's a very important statement. Presence of LG alone cannot be recommended for ICD prophylaxis. However, if the quantum of LG is more than 15%, it can be added as an additional risk factor to ICD assessment. T1 mapping in hypertrophic cardiomyopathy was suggestive of a high prevalence of diffuse fibrosis irrespective of LG. Now let us look at MRI in non-ischemic cardiomyopathy. The prevalence of LG scar in non-ischemic cardiomyopathy was seen in about 41%. The remodeling process in DCM is characterized by changes in extracellular matrix and fibrosis. And the fibrosis detected by LG is a marker for arrhythmias and sudden cardiac death and heart failure. LG scar is associated with a 2.5-fold increase in mortality and 5-fold increase of arrhythmic events. So this is a typical LG pattern in non-ischemic cardiomyopathy, a mid-wall LGE, as you can see very clearly with these arrows. You can see it here. So when we looked at, we found that a mid-myocardial pattern was seen in about 75%. LG was positive overall only in 44%, mind you, in 40%, and was seen in in the septum in 90% of the time. The MACE, cardiac death, heart failure hospitalization, and VT was seen in LG positive patients primarily and predominantly. And when you applied the quantum of LG, the rule of 15% applied in people who had more than 15% of LG quantum, the MACE was significantly increased. So in short, so what did we learn? We learned that the prevalence of LG scar is seen in 40% of NICM with a mid-myocardial localization. LG presence is prognostic of MACE and ventricular arrhythmias and heart failure. And the quantum of 15% carries significant arrhythmic risk and should be weighed in the evaluation for primary ICD prophylaxis, as well as to evaluate the need for CR. So let us look at viability assessment in ischemic cardiomyopathy. Ischemic cardiomyopathy is characterized by hypokinesia, global hypokinesia, wall thinning, perfusion defects, and LG indicating fibrosis. This fibrosis can be subendocardial, which can progress to transmural. So remember this figure. More than 75% is non-viable. So there are a lot of radiology reports which says non-viable, but you need to look at these MRI and get things quite clarified by yourself. More than 75% will be deemed as non-viable. Less than 50% will be deemed as viable, and 50 to 75% is borderline. So typical is an anterior total LAD occlusion. We checked the cine fourth chamber did not show anything specific other than hypokinesia of the interventricular septum. Now you can see the enhancement is more than 50% as seen on the septum, and we deemed it as non-viable. So this is a patient who had, as you can see here, only 25% so deemed as viable, and more than 75% this would be deemed as non-viable. Now, I don't know if I have the time. I would go to how many more minutes do I have?
Ajit, I think you already exceeded the time.
Okay.
I think.
Yeah. So I'll just go to some very specific aspects. Constrictive pericarditis is when you need to distinguish with MRI between restrictive cardiomyopathy and constrictive pericarditis. It is a very important aspect which needs to be looked at. See, the normal myocardium is less than 2 millimeter in thickness, and you can clearly see that the pericardium is more than 4 millimeter in thickness. And when you do at late gadolinium enhancement, you can see the pericardium picks up late gadolinium enhancement, and that is an indication of constrictive pericarditis. So it's very easy and very important to distinguish from restrictive cardiomyopathy. And obviously, you do not have any myocardial LGE. This is the last part of my discussion. Now, this is a patient with endomyocardial fibrosis. You need to look at the apical obliteration of RV, LV, and the typical fist sign that you would see on angiogram also would be seen in MRI. Mitral regurgitation should be assessed, and you can see it in relation to the plastering of leaflets, dilated atria, and typical delayed gadolinium enhancement is seen in subendocardial enhancement with apical obliteration. So I would repeat that. So the very important finding that we have seen, there is subendocardial enhancement of the obliterated segment and atrial wall enhancement as well. So you can see significant obliteration of the apex with the fist sign, as you can see here, dilated left atrium, mitral regurgitation. So beautifully seen on MRI. So you just don't need anything else. And this is the so-called delayed gadolinium enhancement of the obliterated portion of the LV. So this is the typical delayed enhancement that you would see. It does not involve the entire obliterated segment, but just the subendocardial component alone. You would also find there is atrial enhancement as well. So in conclusion, MRI evaluates the anatomy, physiology, and the pathology of the human heart. It contributes to the etiological understanding of heart failure. The tissue characterization can be done by late gadolinium enhancement with T1 and T2 mapping. Now, this has become the equivalent of a virtual biopsy. Scar heterogeneity, which I have not discussed in detail, but the quantum and the heterogeneity has clarified the total arrhythmic risk and has definitely helped in VT ablations as well as in planning the need for an ICD. Thank you.